I am Pauline Whittingham. I am the endocrine nurse for the foundation and been with the foundation now for about 3 years, but knew the foundation very well for a long time before that through my role in the NHS as an endocrine specialist nurse. So we're old friends, me and the foundation. So as Sean has said, we've got quite a few pre-submitted questions to get through this evening. Hopefully the discussion that comes from those will actually help answer some queries that you may have yourself, or may help clarify a few points that you've come across over the years. Very happy for you to share any thoughts or experiences that you may have had that you feel able to share through the chat function, because that may well help some others on the session deal with things, especially with things like adrenal crisis, and recognizing those. If ever you've experienced an adrenal crisis, they're pretty scary things. So mindful of the time, and we've got a fair bit to get through, we should probably crack on with the first question, Sean.
Yeah, okay, I'll just get my screen up again and we'll get going. Okay, so we will start with, I think we've got quite an important question to start with, and that is, what are the signs of an oncoming adrenal crisis?
And there we go, the big one, the scary one. I think most people who have a cortisol deficiency or adrenal insufficiency will be worried about an adrenal crisis. For those of you that have experienced this, you know how scary this can be and how quickly they can come on. So signs of an oncoming adrenal crisis. These can be multiple signs. There can be nausea, there can be vomiting, diarrhea, feeling cold, feeling clammy, sweating. Maybe you'll look pale. You won't notice that, but family members maybe will. Some people will experience a headache, dizziness, lightheadedness, extreme excessive tiredness, muscle weakness. Some patients have reported pain, mainly in the legs, lower back, as one of their telltale signs that they're coming up to a crisis. Breathing may be shallow, may be rapid. Sometimes they can progress rapidly enough so that you actually lose consciousness. So it's really important to be able to recognize the signs quickly and actually respond to them with increasing oral hydrocortisone, or actually having the injection of hydrocortisone. I think that pretty much covers the routine signs that most people would report from an adrenal crisis. As I say, if any of you have any other experiences that you'd feel comfortable sharing, then please do get onto the chat function at the bottom and pop those in, and we can maybe share with the group. We'll go to our next question, maybe.
Yeah, let's. Okay, so these are two questions from the same person, similar topic. There are times when I feel slightly unwell with a set of symptoms that I don't recognise until afterwards, but think later that I have had almost a mini adrenal crisis, perhaps because my levels are low. Is this common to those with adrenal insufficiency? And then the second part is, I usually feel tired, headachy, not sure whether I do or don't want food, but desperately need sleep. The sleep seems to resolve things, and sometimes I need paracetamol too. Should I also take an extra 5 milligrams of hydrocortisone?
Oh, again, this, I think, these or both of these questions emphasize the difficulty in to understand yourself when you are cortisol deficient, and to understand what the body needs and when it needs it when you are cortisol deficient, and how to respond to that. It's really difficult to pick out what is a day where you're tired, or a day where you've maybe just done a bit too much and gone a bit over normal activity levels, or where the adrenal insufficiency is really kicking in and you're going in towards a crisis. Under normal circumstances, the routine replacement therapy that's given should cover you for pretty much every day-to-day event, not a problem. If you are overdoing things in the day, if you've got particularly busy days, I know a lot of my patients used to say when they got a busy time in life, say up towards Christmas, where they'd find themselves rushing around from here and there and everywhere, just as we used to do before COVID, they would find that they became very tired towards the end of those days. That could be because they'd had a higher level of activity, or because in the rushing around they possibly missed their afternoon dose of hydrocortisone and not realised it. So in answer to the first part, it may well be because the levels have dropped a bit. Is it common? It can be for some people, and it's about growing with the adrenal insufficiency once you have it diagnosed, and learning yourself. In terms of the feeling tired and headachy, the needing to sleep, they're going back to what we were talking about earlier on, around the signs of an impending crisis. If this responds to paracetamol and a sleep, it's unlikely to be a low cortisol or an impending adrenal crisis. If the paracetamol and the sleep didn't resolve things, then yes, it could easily be a low cortisol. The caveat to all of that would be to say, if you're in a situation where you think, is my cortisol low? Should I have some extra? Should I take extra cortisol? Taking extra cortisol in those uncertain times, on the odd occasion, will do very little harm, if any. However, not taking the cortisol at those times may very well do some harm and push you over into a crisis. So it's never black and white about these subtle symptoms and whether you should take more cortisol to counteract them. It's always more understanding what your big trigger signs are, what your big crisis signs are, and responding to those to keep you safe. Hopefully that's given enough information to at least answer those two. So if we move on to the next one, Sean.
That's brilliant. Okay, thank you. So, is there an importance in timing to taking my first morning dose of hydrocortisone? I'm finding I'm not taking it till 9:30 as I have to eat with the steroids as it causes stomach problems. However, I have to take other medication that means I'm not able to eat for at least half an hour in conflict.
Okay, so the routine dosing of hydrocortisone is designed to try as near as possible to match the cycle that we, Mr. and Mrs. Average, have within normal circumstances. So Mr. and Mrs. Average will, in the early hours in the morning, the 4 or 5 o'clock, will start increasing their cortisol output, ready for the getting up time. And when you get up, then you get a nice big peak that gets you going in the day. So when we're thinking about replacing cortisol, certainly with hydrocortisone, because that is very synthetically close to the cortisol that we make ourselves, we always aim to take our first dose early in the morning, which is great. The difficulty comes when you have other medication or other health problems that conflict with the ability to do that. We can also see an issue for shift workers with timing of hydrocortisone doses, because if people are working 6 till 2 shift one week and then a 2 till 10 shift the next week and then working a night shift the week after that, that can cause significant issues for those people, because they're forever switching around their day, and so their cortisol rhythm should switch around with it. But ideally, in an ideal world, you would take it as soon as you got up in the morning, so that you were trying to replicate what nature gives. If you can't do that, and so long as you are able to get up and function, so get up, get to the bathroom, do what's necessary there, get breakfast, get other bits and pieces going, then taking it at 9 to 9:30 is what suits and what fits in with your life and what you need to do for the rest of your life and health issues to be met and dealt with. So it shouldn't cause too much of a problem so long as you are taking the cortisol regularly. Hopefully that's helped on that one. Let's go on to our next one, Sian.
Next question is the side effects. I think there are a few in this similar category. So,
yes, there are.
I'll read both of these out at the same time. The side effects from steroids are awful: weight gain, depression, and osteoporosis, for example. Is there any alternative research or other treatments underway? And then the second one is, I am panhypopituitary. Since starting cortisol replacement, I have had trouble managing my weight. Is there anything I can do? I have a low-fat diet and try to exercise without success. I have lost a lot of weight before when I was first ill. There has definitely been a change as my need for medication has increased.
Okay, again, this can be a regularly heard report in the outpatient clinic from patients who are not just steroid replaced, but all hormone deficiencies. I think the more hormone deficiencies that you have, sometimes the worse the problem around weight gain can be. If the steroid replacement is at a level that replicates what would have been provided naturally, then there shouldn't be significant side effects in terms of weight gain, depression, and osteoporosis. Certainly with the hydrocortisone is taken 2 to 3 times a day in divided doses, and it's taken in that way because that particular drug is in the body and out of the body within 6 to 12 hours. So it's very swiftly dealt with and used on a day-to-day basis. Prednisolone is slightly different. That's a much more potent steroid, and that does stay in the body for longer, hence why it's only taken once a day. More likely would be a potential for overdose with prednisolone, and that has a history of weight gain and osteoporosis, but in much higher doses than is used for replacement in adrenal insufficiency. I'm not aware currently of any research into alternative treatments for cortisol deficiency, because the simple thing is, if the hormone is deficient, it needs to be replaced. It may be that if you're having this particular person who's raised the question is having significant problems with the weight gain and depression, then perhaps they need to have a chat with their endocrinologist around the dosing of their steroids, and see if it is actually at optimum level for them, or if it's being overdone a little bit. The osteoporosis side of things, that can often be other hormone deficiencies as well. So testosterone for men, estrogen for women will play into that. So always be sure that those have been addressed. And there's a minor part to be played, but growth hormone will also have an effect on bone composition. I would also say, for those that are maybe newly diagnosed or fairly newly diagnosed, in the run-up to being confirmed as being adrenal insufficient, you may have been many months, even years sometimes, at a low level. And a lower level of cortisol can often lead to weight loss. So it would be perfectly reasonable and understandable that once the cortisol was replaced and the body was able to function more normally, that weight previously lost would be regained. So the weight gain to worry about is that weight that is way in excess of a bit of weight gain. So probably something more than 3 or 4 kilos would be something to raise with the endocrinologist and say, this weight's come on, struggling to do anything about it. Is my cortisol at the right level? What can we do about it? And then start having a look that you're on the right doses for that. Okay, I think we can move on to our next one.
Yeah, okay, thank you. So this one, there's quite a long context on the bottom half of the screen, so I won't read that out. I'll let everyone read that themselves, but it's basically around fatigue and weight gain. Sorry, I just need to move something on my screen because it's in the way and I can't read the top. Sorry, here we go. I would be grateful for any advice that can be given to me, plus I would like to know what investigations are being made into fatigue and the management thereof. I also understand that some food and supplements can interfere with the efficiency of levothyroxine and hydrocortisone. So what advice is available regarding that?
Okay. So one thing to say is I'm not aware of any specific research again around the fatigue that often comes with pituitary disease and pituitary deficiencies, be it one hormone, be it multitude. I know many patients fully replaced all hormones at what you would think were textbook perfect levels, would still have days where they hit a wall and it just all had to come to a stop. Managing those fatigues, which is, I think, is a great way of describing them, can be difficult. I think best thing to do is to sometimes recognize that you will have days that are worse than others, and acknowledge those days are the days that you're going to just stay at home. Maybe have a lay down, a nice long lie-in if you can, if work doesn't dictate otherwise. Have a duvet day, have a little quiet potter around the house. I think Sammy has done some work and has put some information up on our website. Sammy's one of our colleagues who works also as an occupational therapist, and I think she's done quite a bit of work around managing physical activity and managing energy, the energy resource as you recover from a pituitary diagnosis, subsequent treatment, and hormone replacements. In terms of food and supplements that interfere, it's not so much the efficiency of the levothyroxine and the hydrocortisone, it's more about the absorption. So there are times, yes, where some food, some medication, so things that you would take maybe for gastric acid reflux, that kind of thing. So thinking of things like omeprazole or the more calcium containing things, they can sometimes have a knock-on effect at reducing the stomach and the gut ability to absorb these things. So if possible, the levothyroxine and hydrocortisone are best taken separately from other medications and before food. So if you can, take those and then have breakfast, then have tea, coffee, whatever. Any other medication that may be taken once a day, such as omeprazole, you could maybe switch to at, you know, tea time or even later on in the evening, if that would work. In terms of supplements specifically, I'm not sure what the supplements would be unless it was like vitamin supplements. And again, I'd say separate them out. You know, separate them from the levothyroxine and hydrocortisone and take those two separately on their own. Looking at the rest of that question, I'm seeing that the hydrocortisone day curve were increased. So that would say that some of this weight gain that this person's been struggling with maybe isn't due to the hydrocortisone. I would think possibly about maybe growth hormone, but at 73, whether the team would particularly think about starting growth hormone for this person would be another question. Optimizing testosterone may help him as well, or his testosterone level, to make sure that that's there to give enough stamina, enough energy. And obviously making sure the levothyroxine is at the right dose too, because they all interplay in terms of controlling weight, energy, and whether or not you fatigue easily or not. Hopefully that has given that particular person enough information to have a conversation with their endocrinologist about rationalising that lot.
Thank you. Just to say as well, Pauline mentioned there fatigue management that Sammy's written about, and James is going to put a link to that booklet in the chat box in a moment, and we'll also send it in a follow-up email after this session as well, so you can see that on our website. Okay, next question. Shorter one this time.
Oh, nice, quick one.
In instances of sickness, is it the act of vomiting or the risks that the medication is not absorbed the problem?
It's probably both. If you think of vomiting, which is one of the most unpleasant things that a human has to endure, I think, there's the physical stress to the body of the vomiting. There is the thing, whatever it is, that made you vomit. So most likely it's a reaction to a foodstuff, a drug, maybe a bit of alcohol that you've overindulged in, who knows? Or norovirus, that lovely winter one that normally comes to get us but didn't this year, thank you COVID. Any of those, they are a stressor to the body. Then you have the physical action of vomiting, which is also a stress to the body. So if you've taken your hydrocortisone for your, at breakfast time and then you vomit, you've got both of those stresses and your medications come back out as well. So I would say primarily it's the act and the reason why you've vomited, and then adding into that is the fact that the medication may not be fully absorbed. That is the problem. And that's why if there is any vomiting, you need at a minimum to have extra oral hydrocortisone. If that does not stay down, then it's injection and it's a trip to hospital to get that thing stabilized. Because if you are repeatedly vomiting, you will lose volume, you will lose fluid volume, you will need to be stabilized in hospital, maybe only 24 hours, maybe 48 hours. Get that vomiting stabilized, and get yourself stable and safe. So on to the next one. Hopefully that one was a nice succinct.
Yeah, thank you. Okay, next one is, if I decided not to take my medication to manage my adrenal insufficiency, what would be the consequences?
Well, I'd probably have 7 heart attacks, but without taking your cortisol, if we accept the diagnosis is made, you do not produce cortisol. Fine. So you need to take cortisol to preserve life. Cortisol is our life-preserving hormone. It's the hormone that helps to mobilize our blood sugar, to maintain our blood pressure, to help us deal with the stressors in life, be they physical, psychological, environmental, whatever. So if you do not take your cortisol, you have no backup to deal with those stresses. That means when they come along, you cannot cope with them. So what happens? You start to become weak, you start to become tired, you become dizzy, nauseous, not wanting food. And depending on the person, I've known some patients say to me that they hadn't taken it for a while and they felt okay. But still all their tests would say that they wanted it. By a while, I mean a day or two. And then others would say, if I miss a dose, I know straight away because I'm dizzy, the room's spinning, I can't cope. So it can be very person dependent, but ultimately you go down that road towards adrenal crisis. If you didn't respond then with taking cortisol, having an injection, getting recovered, getting stabilized, then it's loss of consciousness. And if at that point still you're at home on your own and nobody bothers to get an ambulance or whatever, then you can very quickly go into coma and it can be fatal. So it's quite a serious consequence to not taking that medication. It's not really a medication as we think of, say, to treat heart disease. So it's not a medication as such that is trying to block the action of something. So as in controlling blood pressure, to, you know, so as a beta blocker or as a diuretic to force water out. It's a replacement for what nature intends you to have, which nature messed up on and got rid of along the way, but still nature intended that you have cortisol. So hydrocortisone or prednisolone in our cases is not a medication as such. It's about replacing and safety. Hopefully that's changed your mind if you were thinking of it.
Hopefully, thank you. Okay, so we move on to the next one. So this is a comment and then 3 questions about so, in most hormone-related illnesses, i.e. diabetes, levels are carefully monitored and adjusted when needed. So first question is, why are people with adrenal insufficiency given a standard dose of steroids? And then, how do I know my body isn't getting too much or too little steroid? And finally, why aren't synaptic levels ever checked once the initial diagnosis is made?
Right then. Okay. Yes, for diabetes, blood sugar levels are checked and medications are adjusted as needed. And that's mainly because people are people and they eat lots of things that maybe they shouldn't do. And especially type 2 diabetes is a scourge of the modern way of living, really. And sugar control can fluctuate throughout life, and with illness, in fact, sugar control can fluctuate. With adrenal insufficiency, a standardized dose of steroids pretty much is used because we know that Mr. and Mrs. normal average produces a standardized-ish amount of cortisol each day. So we know if we aim to give hydrocortisone at between 15 and 25 milligrams a day, that's kind of going to give you roughly roundabout what you would have had your adrenal function remained intact. Getting too much or too little steroid kind of goes back to some of the things we've already spoken of. So too much steroid over a prolonged period of time. So for this, we're talking probably 3 months, maybe more. We're going to start seeing excess weight gain, so over a few kilos of weight gain. We're going to see possible increase in blood pressure, possible moving towards a diabetic state, maybe issues with skin integrity. So you may find that bruising happens much more easily for bumping into things than it used to, or minor wounds don't heal as quickly as they once did. You know, if you cut your finger on a knife in the kitchen or something, it takes a bit longer to heal. Getting too little would be feeling tired, feeling weak, feeling dizzy, especially when you stand up. Maybe sometimes feeling a little bit out of sorts, most people generally describe it as. Maybe not being able to fight infections so much, blood pressure being a bit lower than you would expect, would indicate maybe a little bit too little. Now, those things can be very easily checked, although you maybe don't realize that they're checked when you have your clinic or your telephone appointments, as they are now, with your endocrine team. Because when they're asking those questions of how you're getting on, finding everything all right, and you can say, yeah, I'm doing well, I'm doing this, I'm doing that, that's an indication that normal life is able to continue or is continuing for you. So that too little steroid isn't a problem, because you're not feeling dizzy, you're not feeling tired, you're able to get up and do. And similarly, you've not reported, oh, my doctor says, you know, my GP says my blood pressure is too high, or I've started getting diabetes. And also as how you look when you walk in the room, or they see you on a camera, so they could see that maybe there isn't an excess of weight going on, or, you know, there isn't a lot of body shape change. That can be just a very informal assessment that you maybe sometimes don't realize actually takes place. And why are synaptic levels not checked once the diagnosis is made? Basically because if you've come along with a set of symptoms and then the investigation is done and it's proven that the suspicion was correct, you don't make cortisol, then it's not really very often that ability to produce cortisol returns. Usually there's something in the run up to it, so they'll either confirm that, well, the pituitary, obviously you'll know about if there's pituitary issues, or Addison's disease will have been confirmed in the run up to that diagnosis. The only reason to have the synaptic test repeated would be if you were a patient who'd used steroids for another condition. So one of the inflammatory conditions, a rheumatoid condition or ulcerative colitis, something like that, and you use the high dose steroids, the big high dose steroids that actually can temporarily switch off adrenal function. And in trying to take people away from those high doses, they have to be tapered down very slowly, maybe supported with hydrocortisone, while synaptic levels and synaptic tests are repeated over a period of, up to a couple of years for some. And we see adrenal function returning back to normal for those people. But for those usually with pituitary disease, or a confirmed Addison's picture, it's not usually necessity to have repeated synaptic tests unless your endocrinologist has a suspicion that maybe the pituitary function would be recovering, say, after surgery to the pituitary gland. If Addison's is diagnosed, that I don't think I've ever heard of that reversing, to be fair. Hopefully that's answered that one.
Yeah, lovely. Right, we'll move on to the next one, which again is a longer one with a bit of context. So I'll just read the question, but it's roughly about injuries such as scratches and grazes taking a long time to heal. So the question is, what strategies can one employ to mitigate these effects of long-term steroid use?
Okay. The big thing that kind of hits me right between the eyes there is the dose of hydrocortisone there, and I do hope this is a typo from the person who sent this question in. If it's not a typo, then this is likely the reason why these things are happening to their skin. 150 milligrams of hydrocortisone is a good going dose to be taken every day. That's high. As I've said before, average replacement with hydrocortisone would be between 15 and 25 milligrams. So that is a high dose. If it's 15 milligrams, taken as 10 milligrams and 5 milligrams, that's fine. And ideally shouldn't really cause a significant issue. But I also note that it's borderline secondary adrenal insufficiency. So I wonder if the day-to-day replacement is actually needed. And maybe what this person needs would be sick day cover. Day-to-day, fine to manage on their own. But maybe sick day cover. That's a conversation to be having with the endocrinologist, really. In terms of mitigating damage to the skin, first thing would be have the conversation around the cortisol with the endocrinologist. The other thing would be to ensure, obviously, good diet so that there's enough going in to help skin repair. Make sure the other hormones are at least checked and in place and at adequate levels, so things like thyroid, possibly growth hormone as well. And then if the skin is becoming particularly thin and fragile, make sure it's well moisturized, so make sure that it doesn't become so damaged that it breaks easily of its own. So a good moisturizer to it. And really it's about then, it's hard to say be careful because life goes on and you just want to sort of get on with doing life, and knocks and bangs happen within life. And I can understand the worry about the skin just breaking down into ulcers. It may be worthy having a conversation with the GP and making sure that there's not another health issue that is causing the problem with the skin, particularly in the shins. Sometimes if you've got maybe some heart disease or some high blood pressure, it can cause edema in the lower limbs, and that can cause the skin to stretch and become quite thin and shiny. So just ruling that out with the GP as well would be very, very useful. But the big thing for me would, I'm hoping that zero comes off that hydrocortisone dose and it's a 15 milligram in the day. If it is, it may be that you need to have a chat with endocrinology about that dosing. If it's borderline adrenal insufficiency, do you need that every day? Have those conversations around, and hopefully that will help re-establish the skin integrity. So on to the next one.
Brilliant, thank you. So next one is, I would like to know if there are any supplements that are beneficial to take when you are on hydrocortisone and levothyroxine. Also, are there any supplements that should be avoided?
And it's a kind of along something similar we heard before about supplements. Taking hydrocortisone and levothyroxine on their own, as they are, they're fine. They're replacing the hormones deficient. Shouldn't be a problem. Supplements generally, unless you've got a particularly poor diet and you survive on cornflakes or the like, then unless proven to be deficient in things, there's no real great press to take supplements simply because your hormones are being replaced. If you have a reasonable, balanced, average diet, you should be getting in all of the vitamins and minerals that you need under normal circumstances anyway. Oftentimes we do see with our pituitary patients reductions in things such as vitamin D. So it's always useful to have that checked either through your endocrinologist or through your GP, because that can also then be implicated towards bone strength. But be careful about overdoing the vitamin D, because that will also then knock on into calcium control. So you don't want to be pushing the calcium too high. So it's important to if you're going to replace vitamin, to do it in a supported and supervised way. But in terms of general things like cod liver oil or multivitamins, that kind of thing, there's no real pressing need to take, and there's no real pressing need to avoid them if you feel they help you, so long as you do as we suggested earlier and separate the hydrocortisone and levothyroxine time from the time that you take those supplements as well. Hope that's clear.
Thank you. Right, let's go to the next one. Again, quite a long one. I will read this out though, just to, it's quite an important one for the context. So there seems to be some confusion as to what level of stress counts as sufficient to merit additional hydrocortisone. Some examples are given in various leaflets, but obviously what's stressful for one person might be no problem for others. For example, I have no problem going to the dentist or sitting in an exam, but I find public speaking much more stressful. Since this yeah. Hence why I'm stumbling so much on this question. Since this forms a big part of my academic job, should I watch out for any telltale signs? And then the second part is, this also relates to another question about what to do when feeling washed out, since that will often follow a period of heavy or stressful work. Some days, and this is one, I feel washed out, not ill, but not fully well either. Often it's after a busy few days previously. It doesn't seem to depend on how well I've slept, although sleep is also an issue. Should I accept that I'm not going to be very productive and just rest, or is this something I should deal with by increasing my hydrocortisone dose?
And there we are. This is the thing we were talking about before. The difficulty of knowing when extra steroid is really needed, or is it just going to be that little thing that gives you the lift because cortisol will always give you a lift. That's its action. So the level of stress, generally speaking, it's super stress. So the psychological stresses are things like bereavements, witnessing a significant, traumatic event. So you saw someone knocked over, or you saw a fight in the street, something like that. Actually seeing repeated trauma. So sometimes for PTSD sufferers, this can be a difficult thing, because if you've been involved in a big trauma, having that repeated can often reawaken a lot of those sensations. being involved in accidents yourself is also another stressful, traumatic time. The routine day-to-day stresses of exams, going to the dentist, the dentists are slightly different, but maybe exams or speaking in general should really be managed by the day-to-day dose of the steroid replacer. If public speaking is a big part of your job, that's a bit more difficult, because obviously that's your job and that's what you do and that's your life. But if it's putting a significant stress onto you, that could be worthwhile having a conversation with your endocrinologist about whether or not extra doses at that time is actually valid for you. If you have an academic job and you're speaking to groups each day, that would lead to an overall daily increase in your cortisol. What may be needed is, rather than having an overall increase, which may put you sort of over and above where you necessarily need to be with cortisol, is maybe looking at how those doses are divided over the day, and maybe jiggling a dose around. If you take it maybe 3 times a day, maybe jiggling a dose around so that if you were coming up to do an afternoon speaking session, you could have a dose just before you went in to do that session to kind of get you through it. Feeling washed out, I think, gets reported quite regularly with in patients who have adrenal insufficiency, and it can be a heavy work time, stressful work time. It can be just one of those days really where they just feel washed out. Certainly pituitary patients will report this, and it goes back to what we were saying before about it just being that wall that you hit, that despite all those nailed on replacements being perfect lab figures, beautiful, that doctors like to see, beautiful shiny numbers, you still feel like rubbish. You don't know what's wrong, but you're not feeling right. Those can sometimes be the days where you just need to say, okay, tomorrow's going to be better. You know, tomorrow I'll be all right. I'm going to let today have itself and let it be what it is. And if you can rearrange things, juggle things, fine. Just not be very productive, have a rest. The next day, normally you're back to yourself and able to cope. But certainly if that cortisol thing around the job persists, I would have a chat with your endocrinologist around maybe increasing, but certainly maybe around the timings of those cortisol doses and seeing if that helps for you. Okay, let's see if we've got our next one.
Okay, yep, so we've got about 3 slides left after this, so we will get through them. So this one is, yeah, again, just a bit of context if you want to read it, but the question is basically about the relationship between sugar and carb metabolism and hydrocortisone.
Yes, there is a relationship between cortisol, so hydrocortisone in this case, but cortisol as the hormone, and sugar control. That's how, when you have your insulin stress test and your sugar goes down, your cortisol comes up, because it's coming in to say, get into the liver, which is our cupboard of sugar store, and get that sugar out, get that blood sugar back up, because we can't cope. So realistically, your cortisol actually helps to release a stored sugar from the liver. So at times where you're going along through your day, your blood sugar starts to drop, cortisol will go in, get that released from the liver. That will then get converted into glucose. That will get your blood sugar back up and things go along. So there is a relationship between cortisol and sugar. Now, for anyone that wants more information, very detailed information about that relationship and about how to manage too high or too low a blood sugar relating to cortisol, this link that Sean's put in at the bottom here of a Facebook group is really, really good. It's CAH is Us. It's a group run by Professor Hindmarsh from London, who support primarily people with congenital adrenal hyperplasia. They need hydrocortisone or steroid replacement as well. So a lot of this will apply, but he's written some really, really detailed and very easy to understand explanations about the interaction between cortisol and sugar. It's actually quite complex set of mechanisms. So going through it all now will probably take about an hour. So I would direct to that link there to get the full detailed information about it. Just reading the end of it. When in hospital with diarrhea and vomiting, given futures, blood sugar is tested regularly. It would be because you're getting huge doses of hydrocortisone. And when you get high doses of cortisol, it will put your blood sugar up. There's also a potential, because of the diarrhea and vomiting, your cortisol level would have been low. And so when that's low, your blood sugar would have been low. So it's part and parcel of assessing the recovery and the stability of that process to have that blood sugar tested regularly. So hopefully that link will help understand the actual full mechanisms on that one.
Yeah, and we will include that link in the follow-up email after the session as well, so you've all get to it. Okay, so we'll go on to the next one. Since the end of January, I've been on antibiotics. This has been due to an operation on my eyes. I was wondering whether I should have doubled up on my hydrocortisone, as it states in the sick day rules that if you're on antibiotics, then you should double up. After speaking to an endocrine nurse, she informed me that unless I was severely ill, then I didn't need to. Wouldn't it be better if each and every endocrine nurse gave out the correct information about sick day rules for people taking hydrocortisone?
Everybody say yay! Yes, it would, really. However, each and every endocrine nurse works within a team, and it's the processes and protocols within that team that are relayed into their patients. So antibiotics, since the end of January, this is a tricky one. The general advice around antibiotics usually applies to those that are taken by mouth and given for a distinct period of infection. So you know you've got an infection, so you need hydrocortisone extra anyway, and you're taking antibiotics to cope with that infection. That's going to speed up gut metabolism, as we all know they do. They're horrible things. So yes, you need more hydrocortisone to help with that as well. The problem comes when you've got antibiotics going in for a significant period of time. So you've got maybe, you've got your standard antibiotics that go in for anything from between 3 and 10 days. Then you've got your antibiotics that are given to prevent infection after surgery, maybe in this case, that are given to prevent infection long term. So I'm always remembering a patient I had that had them for, I think it was repeated bladder infections, and they were going to be on low dose antibiotic, alternating between two for life. That was it. Actually arranging hydrocortisone cover in those circumstances becomes a bit more difficult, because the antibiotic kind of sits in the background more than it does in the acute infective taking antibiotics for this. There's also topical antibiotics. I had a call this week actually from someone who'd been given topical antibiotics, so eye drops or skin cream, I can't remember which, hadn't needed to double up. But then GP said that wasn't working, have some tablet antibiotics. Didn't increase the hydrocortisone, and within a day went into crisis because the antibiotics caused diarrhea and etc., etc. So it is always a difficult one. And I would think if you're going to be on an antibiotic for a prolonged period of time, so if there's no obvious infection and you're getting an antibiotic as what they call prophylactic use, so to prevent infection following a surgery, definitely contact your endocrine team and say, this is what I'm facing, what do I do? If you start to have symptoms of a low cortisol, so the dizziness, the tiredness, the feeling weak, maybe a bit nausea, contact the nurse back and say, look, I know you've said not or whatever, but I'm feeling this way. And you maybe don't double, you maybe go halfway for a time if you're going to be on them for 2 or 3 weeks. There's fluctuations and adjustments that can be made, but you need to do it under the guidance of your team and with their input and their supervision of that. So hopefully that's helped to clarify that confusion. I know it can be very confusing actually to know the exact time with antibiotics.
Okay, right, and we'll move on to then the all-important topic that everybody wants to know. So, what COVID vaccine group should pituitary patients be in? Okay. I've had my pituitary gland removed, which means I have panhypopituitarism and diabetes insipidus, yet my GP has said I'm in group 9. I know that I'm not at increased risk of catching COVID, but if I contracted it, I'd probably be more unwell. Mm-hmm. And then to follow on from that, for someone on full steroid replacement, should they increase their dose when they have the vaccine? And would that just be on the day of the jab or also for a day or 2 afterwards?
Okay. In terms of the vaccine grouping, I think we've got our link there at the bottom of the slide. Advice from our medical committee, advice on the Addison's disease group. Also group 6, which is 16 to 64 years of age with an underlying health condition that places that person at more risk of serious illness or death should they contract COVID-19. So you are right, panhypopit and diabetes insipidus definitely would mean if you contracted coronavirus, stabilizing and managing that would be very much more complex than your average 16 to 64-year-old. So yes, group 6. I've had a few patients, well, several patients ring me on this one, and I've directed them to that link. So taking that link into their GP has actually helped them have their group reassigned. So if that's an issue, you could try doing that. And in terms of steroid replacements for their vaccine, again, I've had quite a few come back to me on this as well. There's no real need to increase the steroid on the day of the vaccine, but we are advised by Professor Was to have some paracetamol on the day of having the vaccine. If you would start developing some of the side effects that can come with it, then that can be an indication for increasing the hydrocortisone for a day or 2. Side effects that are reported are a mild fever, feeling fluey, aches, pain, shivery, shaky, joint pain, muscle pain, some nausea. So any of that starts to happen, headaches as well, I think have been reported. Any of that comes along, definitely increase the hydrocortisone, definitely, for a day or 2. And I saw one question pop up there about should I ask the nurse every time? I would say no, not every time that you increase, because obviously sick day rules are basically placing that responsibility with you, the individual patient. But I think it was going back to that last question we had about the longer term antibiotics. It's more about when you're facing a long-term antibiotic therapy, speak to your nurse about it then. But for things like, say, the vaccine, you have that and you get some side effects, you don't need to ask. That's expected, part of your sick day cover, part of your management of your condition. Double them up, keep yourself safe. I think that's it.
Yes, I think that is the last of the pre-submitted questions. We've got through so much. We could go on and on, but we do have that one last question, Pauline, that we brought up, but we would like to include. I am aware of time, but it's a really important one. So anyone know that needs to leave, that's totally fine. So this last question, really important, so we wanted to include it. So I have adrenal insufficiency, and about 5 years ago, my doctor said I no longer needed my emergency injection as ambulances now have hydrocortisone on board. Is this correct, or should I still have an injection?
When Sean first told me this, my reaction was, you should all have your injection still with you. You should. You have adrenal insufficiency. That's not changed. You take cortisol every day. That's not changed. You should have an emergency injection. I know from speaking with so many people, so many patients, not all ambulances will give hydrocortisone injections. So yes, you should have one with you, definitely. You should get that through your endocrine centre, and they should forward that information to your GP. So they give you the initial supply, they give you the initial needles, syringes, etc. As you use it, or it goes out of date, hopefully, that's what happens rather than it being used, your GP repeats the prescription and keeps that supply going for you. But you should have that to hand. You know, if you had a norovirus that can hit you out of nothing, you can just be sat one night watching TV, and then the next thing you know, the whole world's collapsed and you don't know which end is the worst end. You need your injection there and then, because the stress that's going to places on a normal body is intense. But what it will do to somebody with cortisol deficiency doesn't bear thinking. So yes, you need your injection. I would very strongly recommend a conversation with said doctor and have that re-established, definitely.
Thank you, that's brilliant. Right, I'll just stop sharing this now. I can suddenly see everybody again, so I couldn't see anybody for a long time. So thank you so much to Pauline for her time this evening. Thank you, Pauline, for answering so many of your brilliant questions that you all submitted